This is the pulmonary screening examination. We will be performing the observation, inspection, palpation, auscultation, and percussion. The purpose of this examination is for the therapist to identify any abnormal findings which would warrant more advanced inspection techniques or a possible outside referral source. We start off with just looking at the general appearance of the patient, if they are obviously alert and cooperative during the examination, if there's any signs of distress or labored breathing. We can see here that Graham is in a benign unconscious state of breathing that is performed with ease. Looking at his respiratory status, the rate, the rhythm, the depth, and the pattern. His inspiration to expiration ratio should be a 1 to 2. They should be fairly deep breaths, not shallow breaths, and we shouldn't be able to hear any noise with a normal, healthy breathing patient. We can look closer into his facial expression if there's any signs of possibly grimacing or distress, any diaphoresis, looking at the skin condition and color for pallor, cyanosis, specifically of the mucous membranes of the lips or the nail beds, or any abnormal changes such as clubbing. We also can see here that Graham demonstrates the normal diaphragmatic breathing for a normal patient. In some patients, we would see accessory muscle breathing where they're using their neck muscles, such as the scalenes and the sternocleidomastoid, to assist with their expiration in our COPD patients. We can see also that there is a symmetrical inspiration and expiration of the chest wall. We can look also for the sternum. We would see in some patients a pectus excavatum, where the lower portion of the sternum takes a more posterior positioning. We want to point out certain landmarks that are also important to identify underlying pulmonary structures. Looking at the sternum, the suprasternal notch, just above that would be the trachea. Following that down the manubrium to the angle of Lewis would be the second rib location. Down the body of the sternum to the xiphoid process. Along the sternum, we have the costochondral junction. At the xiphoid process would be the joining of the right and left costal margins. This angle should be 90 degrees or less. If it is greater than 90 degrees, that would typically be seen in a patient with emphysema who would take on the position or posture of hyperinflation of a more horizontal position of the ribs. We would be calling that a barrel chest. We also could see that in comparing the AP diameter to the transverse diameter of the thoracic cage. Normally, this should be a 1 to 2 ratio or a 0.7 to 1. With a barrel chest patient, this would be more equal in diameter. Important anatomical landmarks to point out. Again, the second rib would be at the location of this angle of Lewis. Following that down to the fourth rib, which would be the horizontal fissure, down to the fifth rib, which is the mid-axillary line. The sixth rib is the mid-clavicular line. Eighth, ninth, and 10th rib would be the false ribs because they're joined together by costal cartilage. Moving to the back, the 11th and 12th rib would be our floating ribs. C7 is the location of the apex of the lung. T3 is the oblique fissure separating the upper from the lower lobes. T10 would be the base of the posterior lower lobes of the lungs. So I'm going to warm up my hands as much as possible before beginning the palpation portion of the exam. I'll place my hands on your back. And if you can just take a deep breath in and out through your mouth. Good job. While he's doing that, I'm watching for symmetrical range and movement. As my thumbs separate, they should separate a distance of 1 1/4 to 2 inches for symmetrical movement. You can assess the upper, middle, and lower lobes of the lungs. If one area or one side is moving less, that would be the side to further look into of a possible disease state underlying in that lobe of the lung tissue. Now moving on to the palpation. Graham, as I move down your back, I want you just to tell me if any area is tender or painful. So I'm just going to be pressing along the spinous processes, checking for the normal alignment. If anywhere is painful or tender, according to the patient, feeling for any lumps or masses, moisture, and then the temperature of the patient's skin. Any tenderness in the muscles. Moving down along the spine, down to the lumbar spine. And moving on, this would lead us into the auscultation portion of the exam. If we're warranted, we can do an advanced palpatory technique, which I'll do prior to the auscultation. This is if we believe there may be something more going on with the patient. So I'm going to check the tactile and verbal fremitus, which is feeling for the vibration while the patient speaks. Graham, could you say 99?
99.
And again?
And again.
I'll say 99 again.
99.
99.
99.
99.
99.
99.
99.
Thank you. And so what I'm feeling for is the amount or level of vibration under my hands comparing side to side. And as I move down the thoracic cage, if there was an increase in vibration, that could indicate pneumonia. If there's a decrease, or I can hardly feel that vibration, that could indicate fluid in that area, or an emphysema, or an enlarged lung. So now for the auscultation portion. Graham, I'm going to have you just cross your arms in front like this. And can you take a deep breath in and out through your mouth? Deep breath in and out. 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 Deep breath. And one more. Good. And you can relax your arms down. During that, I'm listening for normal breath sounds, which in this area I should be hearing the bronchovesicular sounds, and more lateral to that, down and out around, would be the vesicular breath sounds. Abnormal sounds may be wheezing or rhonchi, crackles or rales, which would be evident in pulmonary edema. And then the wheezing would be asthma or emphysema. Then I'm going to move to the percussion portion. Graham, can you hold your arms up again like that for me? And go ahead and relax your arms. So during the percussion portion, I'm going to be listening for a normal, healthy lung would demonstrate you would hear a resonant note. If there's hyperresonance, that would indicate an hyperinflation or emphysema. If there's an unexplained dullness, that could indicate a mass in that area or a consolidation in that area of the lung, such as with pneumonia. Then moving to the anterior thorax, I'm going to continue with the auscultation and percussion in that area. Graham, can you take a deep breath in and out through your mouth? Another deep breath. Another deep breath. And again. And again. Again. One more. Good. And then I would perform the percussion in the same areas. And that would conclude our pulmonary screening examination.